And I'll tell you a little bit more about some newer options, but right now, what we're comparing all the new treatments against is we get an overall response rate with 5-azacitidine, which is the generic name for Vidasa, of 51%. That means about half of our patients are going to get better in some way with Vidasa. Usually that means their blood cell counts are going to get better, they may come off of transfusion, and by this graph where they were compared to just doing blood transfusions, they're going to live longer as well. However, sadly, we're only achieving a complete remission where we make the genetics go back to normal, where we get all of the blood cell counts to a high enough level that we can call that a normal CBC or near normal CBC. We're only getting that in 16% of the patients. So as you can imagine, we and you really are desperate to find ways to make these drugs either work better or last longer, or to up that CR rate if it's going to mean even better long-term survival. So that's what we've been working on. The other FDA-approved agent that's sort of a cousin of azacitidine, it works the same way, is called D-cytabine. Now, I wanted to get back to allostem cell transplant, although Dr. Akhtari is going to tell us a lot more about that, but it's really still the only curative option for this disease. And I want to make it really, it is a high-risk procedure with transplant-related mortality of around 20%. Some studies show higher, some studies show lower, so I average it out at 1 in 5 patients can die from this approach. On the other hand, patients who can get through that initial 300 days of transplant and afterwards can do very well and can actually be cured of their disease. The donor age is actually becoming more and more important. So how old the donor is, because of some of the things I mentioned, where we're seeing that even normal older people can have some mutations in their stem cells. So we want younger donors. But the age of the patient in and of itself is really not the cutoff for determining if somebody can have a transplant. It's how well they are. Do they have other diseases that we need to worry about that are going to be a problem in transplant? So there used to be a joke that however old Fred Applebaum is the oldest age that you can have a transplant, because he was one of the big original transplanters. So when he was 70, then the age was 70, and then, you know. So we really don't have a strict age cutoff. So if you feel that this is something you would want to take the risk of doing, you should be evaluated at a transplant center and the decision made between you and the transplanters, rather than someone just telling you, oh, well, you're 69, you can't have a transplant. That's really not how the guidepost anymore. And then I won't talk much about this. These are different outcome studies for transplant based on some of those genetic risk factors. Dr. Akhtari may talk more about that. So I'm going to move into the last segment, which is about novel therapies. What can we look forward to? But does anyone have questions about the standard therapies? Yes.
Oh, regarding the transplant?
Yes.
What if, as a possible donor?
Yes.
Oh, I'm sorry. As a possible donor, can a person with lupus or hepatitis A?
Can you save that question for Dr. Akhtari?
Oh,
because
sure.
he's an expert in transplant, so I want to make sure he's got questions to answer when he gets up here. Yes?
Can you go back to the Revlimid slide
Sure.
for a minute? That I just want to copy that.
Oops, yeah, sure.
Okay,
And
thank you.
we are going to make the slides available to you guys, and I believe Audrey's going to email them to you, so you could go back and look at them. Yes, question?
Is there any thinking about when you start Vidasa?
Yeah.
And it's better to hold off until you really need it type
Right.
of question?
You know, that's a very good question. So I was talking about that with someone earlier. There was a study with oral Vidasa in lower risk patients. So this was a version of Vidasa that we knew gave lower blood concentrations of the drug because it was taken as a pill, so it got degraded by some of the enzymes in the GI tract. And so the company said, let's see if these lower doses could help lower risk patients. We're kind of waiting for final, word on that, but unfortunately, it looked like there was toxicity. So just as somebody pointed out, if you're in a very low risk category, exposing you to the toxicity of a treatment, even though it's not that bad and it's nothing compared to intense chemotherapy for other cancers, but it may not behoove you to do that because you may not actually get a survival benefit if you already expected to have an 8 or 10-year survival. So right now, with these standard agents, there's no data to support that starting earlier is better. On the other, that meaning in the low risk state. On the other hand, if you're intermediate risk or higher, the data support that there was a survival benefit. Now, we don't really know, some of those patients may have already been living with their disease for a few years by the time they got on that trial, so that doesn't really answer the question of whether waiting is better. What I don't like about waiting once somebody's already in the intermediate risk state is that if there's DNA damage happening, then I know that those stem cells can get more DNA damage. So if I see evidence for DNA damage, there's more blasts, we're acquired a new cytogenetic mutation, I feel much more concerned that we do need to start treatment to kind of pull the process back. Yes?
Can you go back to Revlimid after you've been in transfusions for 5 years, 4 years?
After having been treated with it previously, you
Yes.
mean? So if you were treated with it and it worked and then it stopped working, I'm not aware there's any data that you will start responding to it again later. However, if you were getting it and it was working and you stopped even though it was working, there is a chance that going back on it could help.
That wasn't the case, it just
Okay.
stopped.
Yeah, if it stopped working, you know, it does have toxicity, especially neutropenia. I don't think it would be worth the risk of going back on a drug that had stopped working.
Thank you.
Okay, good to move on. Okay, because we have to get Dr. Antari up here in just a few minutes. Okay, so now we're going to talk about, oh, I lost the title slide. Now we're going to talk about what's happening, new options. These are not FDA approved, and these come from the abstracts at our American Society of Hematology meeting in December, just a month ago. And that's really where people come and show us, you know, what their trials are doing, what are the results, before they actually get published, before they actually get FDA approved. So the first trial is the Medalist trial, and this is with a drug called luspatercept. Shoot, I lost the slide there. The luspatercept is an interesting drug that works through a totally different pathway, not methylation related, that helps red blood cells grow up into more mature red blood cells. And so it already went through phase 2 studies and looked promising, and it's being used in non-cancer diagnoses too, like hemoglobinopathies, thalassemia you may have heard of. And those patients seem to be responding by improving their hemoglobin even though they've been anemic all their lives. So in this trial, it was a phase 3. When it gets to phase 3, that means they're trying to take the drug to the FDA to get approved. And this is a placebo-controlled study, so the patients either got luspatercept or they got placebo, which was also an injection under the skin, but there was nothing in it. And they had either very low, or they could have intermediate risk with ringed sideroblasts and getting transfusions. So all of the patients were on transfusions for this study. So that means they hadn't gotten Vidasa yet, they hadn't gotten decitabine, they were just getting blood transfusions. So 38% of the patients treated in this group at 2 months had achieved transfusion independence. At 12 weeks, it was about 28%, and then they have a 24-week that was about 33%. So somewhere around 30% of patients with sideroblastic anemia specifically, who are requiring blood transfusions, appear to respond very well to this drug. So somehow it's pushing the development or the maturation of those red cells out to fruition, and those red cells start coming out again. So that's extremely, extremely exciting. It's a novel way of treating MDS. We're really excited, And as somebody was saying, they've been calling the company and trying to figure out, but it's gonna be the FDA that's gonna decide when this drug can actually come to the masses. It's very well tolerated. It's an injection under the skin every 3 weeks. So not bad. Yes?
Would that be appropriate to give somebody that is transfusion independent?
Yeah. So right now, you know, the studies are designed very specifically because in order to get FDA approval, you have to show that you met an important endpoint. And the important endpoint is being on transfusions and coming off transfusions. So that's what the company chose. Once the drug gets FDA approved, that's a different story. Each and every physician with their patient, they may say, well, my patient's not transfusion dependent because he walks around with 5.6 grams of hemoglobin and he's fine. But I want to give him the drug because he really should be on transfusions and it's likely to work for him. So that will potentially be a little bit subject to differences in care once it's FDA approved. But right now, no, it can't be given to anybody other than in clinical trials with a very defined endpoint.
Were there any side effects that they?
So, you know, it's funny, in the current presentation, they did not talk about too many side effects. And the one from last year, the phase 2, I think there was some headaches. The side effects seemed very mild, actually. Dr. Akhtari, do you remember if there were any significant side effects with this one?
No, very
Okay.
tolerated.
I knew that someone was going to ask me that, and I combed through the abstract. There was nothing about the toxicity in this trial. But this is not the full publication. This was just the abstract at ASH. And then the placebo-treated patients, somehow, some of them, I think they were able to get ESAs, did get transfusion dependent, but nowhere near the number on the luspatercept. So really promising, really exciting. A second drug that looks like it's very promising, which is a little counterintuitive in my opinion, is called imetelstat. And imetelstat also has a totally novel way of working by inhibiting telomerase, an enzyme that caps the DNA and protects the DNA. And the idea is that the cancer cell may be using this enzyme to protect its aberrant bad DNA. And so if you stop the cancer cell from being able to do that, then it'll fall apart and die and the good normal cells will come through. So this also was a group of patients who are transfusion dependent with lower risk MDS, who had already received Procrit and failed, or the Procrit stopped working. And they were not the Revlimid group, not the 5Q minus group. So not having received Bideza, but also not necessarily sideroblastic anemia. This was all lower risk MDS. Again, almost the same overall response rate, 37% achieving transfusion independence at 8 weeks. Again, that's seeming to drop off a little bit at 24 weeks, but that could just be, okay, so you came up to 9 and now you're at 8, so we gave you a unit of blood. We're gonna have to see, because these are small studies. This one's only 38 patients, but patients were, median time until they got off of the blood transfusions was 2 months. And the median duration, so if they got off of the blood transfusions, the median duration of how long they could go without going back on blood transfusions hasn't been reached. So very, very interesting results here by David Steensma from Harvard. This one, unlike the other one, does cause neutropenia though, and thrombocytopenia. So I am concerned about this. It's 1 in 4 to 1 in 5 patients where their blood cell count's dropping the other blood cells. So I'm not as excited about this one as I am about the luspatercept. This has also been used in myelofibrosis with some concerns of the same, dropping some of the other blood cell counts. All right, this is guadocytabine. This is a new hypomethylating agent. So just like the 5-azacitidine or Bideza, then the D-cytabine, the concept here was that your body actually degrades D-cytabine within 90 minutes. So you have these enzymes that just chew it up and get rid of it. So this drug was made so that it could last longer in the bloodstream, which is shown here. So these are different doses of guadocytabine. This is how long IV D-cytabine lasts in the system. The body's gotten rid of it within 2 hours. So the concept is, well, if we can get it to stick around a little longer, maybe it'll do a better job of getting into those bad leukemia cells or MDS cells, and then causing what we needed to do, which is picking off those methyl groups. So we have worked with this guadocytabine since phase 1. We've had a number of patients benefit from it. And at this year's American Society of Hematology meeting, the MD Anderson group presented guadocytabine for the first upfront treatment for patients with MDS. It was 97 patients, and their overall response rate, remember I said it was 51% for Vidasa, was 65%, so pretty good overall response rate. And the CR, complete remission rate, which was 16% with Vidasa, also looks a little bit better at 26%. Now this is only a phase 2 study, so hard to say, but patients are definitely responding to this guadocytabine, and that's also been my experience. So moving from that, there's a whole category of treatment in cancer in general that's about waking up our immune system. So cancers seem to have the ability to turn your immune system off, to say, no, I'm supposed to be here, I'm part of your body, go off and kill a virus or something, you shouldn't be killing me. This is the cancer cell talking. And there's a bunch of things on T cells, our T lymphocytes. So remember I said I'd get back to the other part of the immune cells, the lymphocytes, which are usually not affected by MDS. But what we think may be happening is that this is a T cell, this is a cancer cell. The cancer cell has little markers on it that when it connects to a T cell, the T cell says, oh, okay, I'm not supposed to kill you, and quiets down. We're using the term immune exhaustion when that happens to a bunch of T cells in a cancer patient. So drugs have been designed to try to block that interaction so that the cancer cell can't turn off the T cell. And so far, these drugs have now been approved for melanoma. That was the first cancer where they were shown to be really active in about 15% of melanoma patients. But in those patients, they work really well. Jimmy Carter, remember he had melanoma, metastasized to his brain. He's alive and in remission because of these drugs. The second category were genitourinary, so patients with bladder and renal cell are benefiting from these drugs. And the third are patients with lung cancer. So we wanted to see whether maybe some of our patients are losing their response to Vidasa or to decitabine because their immune system is just getting exhausted, and so their immune system starts to shut down. Other investigators are also very interested in this, so there have been several studies, some of which were presented this year's ASH. This is a phase 2 study where they took Vidasa and they added one of the 2 approved immune checkpoint inhibitors, and they got overall response rates in the 60 to 70% range for patients who had never been treated before, and they got CRs of 40%, which is very impressive, much better than what I've showed you so far, 16%, maybe 26% with guadocytabine, here 40%. So this is only one institution, one small study, hard to say. The second one was out of the Cleveland Clinic, so this is an MD Anderson study. This is the Cleveland Clinic with azacitidine and atezolizumab, another immune checkpoint inhibitor, and they also got a very good overall response rate in the 60s range, which is better than the 50s range, but the CR rate still looked the same in their group. So what we've done is to say, let's take the best hypomethylating agent and put it together with what we think will be the best and safest immune checkpoint inhibitor, so guadocytabine plus atezolizumab. And what we wanted to do is give it to patients who've already received standard therapy with either Vidasa or decitabine and see if we can resensitize them and get them to start responding again to that therapy, since we know that these hypomethylating therapies work and they're safe. We completed our phase 1, and then we had that as an abstract at ASH this year, and it showed that the dosing for the guadocytabine when given with the atezolizumab was considered safe in the first 9 patients. And now we've moved into our phase 2 study. So far in the phase 1, now remember, these are patients who already had the other therapies. Their expected life expectancy after the Vidasa fails is only 5 to 6 months. And we're getting an overall response rate of 33% in the first group, so 3 out of the 9 patients, and one of those patients is in a complete remission with normal blood cell counts off of transfusions.
So would you say that this kind of therapy would be good for someone that has MDS and also has, let's say, HIV?
Yeah, so, we can't say that yet because it doesn't make you have more T cells. What it does is that the T cells you do have, it wakes them back up so that they start recognizing the cancer cell the way they're supposed to and getting rid of it or attacking it. So it doesn't actually make the T cell go up per se. So I will introduce you to our CR patient in just a moment. There's another drug that's still out there that still has a chance called rigosertib. We still have a phase 3 trial with this. In the initial studies, it didn't show an improvement in overall survival for the patients like the ones I mentioned. Vidase already stopped working for them. However, it looked like in a group of patients who were very high risk, they actually did do better. And so now the trial is just for patients with really high risk disease and who are within a year of having been exposed to Vidase or decitabine. So it's a really select group. It's been very hard to enroll on this trial, but it is accruing patients. I think we have over 250 patients now. So we'll see if we're able to bring benefit, especially to patients who go on Vidase or decitabine and don't respond. So there is some hope with that one. And it works through this pathway of RAS-RAF. The overall response rates in people who have never been treated with high-risk MDS were very high in their earlier studies. And they've now created an oral form, a pill. So there could be some really exciting things there. There's also some abstracts where they combine the drug with Vidase. And then here's one last thing for the P53. P53 mutations, as someone pointed out earlier, make MDS worse, for sure. Those MDS patients with P53 mutations, it's harder for us to get them into remission. They're harder to treat. This is a new drug that specifically targets the P53 mutation. It's called APR-246, and it was given with azacitidine with dramatic results. We have nothing that gives us results like this, with or without the P53 mutation, but especially with the P53 mutation. So we're really, really excited about what this might mean for our patients. There is some GI toxicity though, and there is peripheral neuropathy, which is a real issue. And then there's a couple of other things that are out there that are coming soon in clinical trials. I can't say much about them yet because they're very, very early, but look for clinical trials if you're at that point where the other drugs aren't working. And I just wanted to show you, this is from our clinical trial, a patient, well, maybe it won't allow me to. Do you know if it'll allow me to play a video on this computer? Or?
Sure.
Okay. Somehow it just flipped off. Let's see if this works. There it is. I'll do that first.
I don't know if it'll play the sound. Yeah, whether the volume will go there.
No, it doesn't seem to be allowing it. I'm gonna try again. Or maybe because it's on pause. No. Darn.
I don't know if it'll allow to play
Yeah, I
sound
guess it
there
won't.
through that. Yeah, I don't think it will. It's only connected for the slides.
No, I just started. Here, I
Slide the
can.
volume up.
Let me see what the volume is.
On the far right
Oh,
bottom.
here we go.
More than 12,000 people have been part of clinical trials funded by the
Trying to
money
think of
raised here.
where
We
the
spoke to one of
volume
those
is.
people who says he is alive today because of Stand Up to Cancer. Something as simple as walking his dogs is something Arnold Espino could not do recently.
My dogs won't produce blood, the oxygen that I need. I couldn't go upstairs.
Yeah, it's a good idea, but I don't know where it's
Espino was
coming out.
diagnosed with a rare blood disorder called mild School of Medicine of USC. The trial was funded by Stand Up to Cancer.
And we take discoveries in the lab and quickly get them to patients who are suffering with cancers, because that process can be very, very slow.
It's a bench-to-bedside approach which Stand Up to Cancer uses, along with the Dream Team model, where researchers from across the country work together.
Conditions like MDS that don't have a lot of treatment options, the magic and the hope and the miracles are made in clinical trials.
After Espino's third treatment at the clinical trial, Dr. O'Connell gave him the good news.
He said, your counts are normal. You should have seen her. She was so elated.
Can't believe he's talking about me instead of himself.
Complete remission, which we're all incredibly excited about.
Espino is excited too, now that he has an opportunity to watch his grandchildren grow up. In honor of tonight's event, more than 130 iconic buildings across the U.S. and Canada will light up in the Stand Up to Cancer colors, including the LAX pylons, the Capitol Records building in Hollywood, and the Pacific Wheel at the Santa Monica Pier in Santa.
That was just a prelim on the prelude to the Stand Up to Cancer telethon that they have every year. So anyway, but our patient is from the clinical trial that I mentioned and off of transfusions, normal CBC. We're over a year out now. So that's really exciting, and we're hoping to see more of that. So thank you, and I'll take any questions on the novel. Yes, sir.
Where does venetoclax fit in?
Yeah. So venetoclax is very, very exciting for currently approved now for AML with low-dose Ara-C. So low-dose Ara-C isn't something that a lot of people use, but it has been an old standard for more than 2 decades. So most clinicians kind of want to see some data with the venetoclax with something that we actually use, like Vidasa, decitabine, or one of those. And although the preliminary data for MDS also looked really good, I guess the company decided to go for AML for their FDA indication. So we kind of have to wait and find out what's going to happen for MDS. But if we see that the disease evolves into AML, that is definitely something, if you're not going to do a clinical trial, that could be considered in that setting. And venetoclax it works through the apoptotic pathway. It's already approved for a totally different part of the blood cell cancer side, which is CLL, chronic lymphocytic leukemia. Yes?
I believe my brother is intermediate.
So I'm just wondering, would we maybe try the Vidasa and all that first before really talking about bone marrow transplant? or
Okay, but
stem cell?
remember that the Vidasa isn't going to cure him permanently. So these things should be done in conjunction. So if he is a candidate for a clinical or for a bone marrow transplant and would want a bone marrow transplant, then the work toward that should begin now, because the Vidasa may work great, but it's not going to work forever. And if it's working, that'll be the optimal time to go into the transplant with a clean bone marrow and try to optimize the long-term remission that we're hoping to achieve.
So if he's, very weak or whatever, stem cell might be maybe too risky?
Well, right at this moment,
Yeah.
he would probably feel a lot better and therefore be able to sustain a lot more if we could get the hemoglobin up with the treatment, Vidasa,
Okay,
before heading into the transplant.
okay, thank you.
Yes, sir.
I was wondering, how does the aberrant T cell affect the thymus gland? Because they're stored there.
Yeah, so the T cells actually go to the thymus in order to learn about the antigens or proteins that they're supposed to fight. And a lot of that happens when you're a child, and then the thymus gland actually kind of shrivels up after that. So there's still some action that happens in the thymus, but there is these are all mature, what we would call post-thymic T cells. They've already become CD4, CD8, killer type cells. So they're not immature T cells that we're looking at, they're mature T cells. So you don't really need the thymus anymore for the medicines to work or for the T cells to work. Okay,
Just real quick, you mentioned, well, one of the symptoms that we're observing with my mom is just severe fatigue.
Yes.
Will the Procrit or Promacta or Evogen, will those alleviate that to a degree, or
So-
what do you do to work on that
Yeah, we
fatigue?
can't say with 100% certainty because some people who are on Procrit, and we get the hemoglobin from, let's say, the 7s up to 9, don't necessarily feel 100% better.
Yeah.
But they may feel 40% better or 50% better if we get those blood cell counts up a little bit. We don't really have a treatment that's specifically for the fatigue. So I would start with those measures, try to see if you can get those blood cell counts up and if she feels better. But obviously if the hemoglobin is dropping, especially below 8, then she may feel better with a blood transfusion. And so you don't, just because there's iron in the blood, you can get 20 bags of blood before you're really gonna start accumulating. So I wouldn't try to avoid transfusion because of the iron in this moment of her care,
Yeah.
especially if she's feeling really poorly. The other thing we always need to make sure to do is her heart okay? Are her lungs okay? Is there any other comorbid condition that we could be working on to also help maximize how she's feeling?
The initial paperwork said myelofibrosis as well, but we need
Yeah.
to get that checked out. What's the drug that treats that? Or
So,
what combination?
if she's feeling really bad, has sweats and is losing weight and has a big spleen, then ruxolitinib, which is a JAK2 inhibitor, is extremely effective at symptom control. It makes people feel better. There's
What-
just no doubt
what's that?
about it.
What's it called?
Jakafi is the brand name. Ruxolitinib is the generic name. RUXOLITINIB. And patients with big spleens and really bad myelofibrosis related symptoms will feel much better with that drug. The problem is it makes the hemoglobin go down.
Big spleen,
So-
would you see a enlarged
Not
belly or?
necessarily.
No?
The
Okay.
physician has to feel it or ultrasound it to document
Okay.
that.
Thank
She
you.
may feel pain there, but it's not gonna be visible to the eye.
Thank you.
Okay, I'd like to introduce my colleague, Dr. Moji Akhtari, who is a wonderful stem cell transplanter with us at Morris and USC. He's going to talk a little bit about that in MDS. Okay, so. Let's see which of yours. Which one is yours?
Good morning, everybody. Can you hear me, everybody?
We may have to move it up just a little.
Good morning, everybody. It's an honor and privilege to participate in that program, and I would like to thank you, MDS Foundation and my colleague, Dr. O'Connell. I'm going to talk about stem cell transplant and its role in patients with MDS. Obviously, as Dr. O'Connell mentioned, transplant, the best way I describe it is like a big stick, and you can't use it for all patients. The best way to describe it is that we usually try to be cherry picking. It's a very selected therapeutic intervention for selected patients. But when I see a patient for transplant consult, an MDS patient, the first question that I ask myself and the patient and his or her family is that, what is your IPS score? Obviously, as Dr. O'Connell mentioned, this IPS, when it originally developed, these were for patients who did not get treated, but these days most patients are on some type of treatment. So two big categories. low-risk disease versus high-risk disease. If a patient is low-risk, that patient is not probably a good candidate for transplant, but there are certain exceptions that I'm going to talk about. So that's the first question. Tell me about your IPSS, what risk group you belong. Number two is talking about the changes in chromosomes. There are, as you know, there are certain chromosomes which are bad actors. For example, if a patient has 3 changes in the chromosomes, or more than 3 changes, we call it complex karyotype changes. Those are usually bad actors. Those changes are telling us that that patient could progress to acute myeloid leukemia faster, so we need to be more proactive. Does it make sense? So it's this IPSS is going to tell us how the patient's disease is going to act. And then obviously we need to look at the fine prints. For example, if there are abnormal changes in the chromosomes, tell me how many we have and in what chromosomes. For example, if there are changes, we call it monosomies. For example, if there is only one pair of chromosome 7, usually, as you know, we have pairs of chromosomes, yes? But if there is only one chromosome 7, that's not good. Those patients could do worse, that I'm going to talk about it more. And so that's how it shows that patients who have high-risk disease, for example, if there are blasts in the bone marrow, they do worse. This is from the original paper which introduced the IPSS in late 90s. And then we have a WHO prognostic scoring system that these days is not that much in use, but it looks, for example, at the transfusion requirement. And we know that like patients who have frequent transfusions, they might be in trouble. As Dr. O'Connor mentioned, 1 bag of red blood cell, it gives the patient 200 milligrams of iron, and too much iron is toxic to our body. And there is data, for example, if a patient is having at least 2 transfusions per month for at least 6 months, this is actually a bad situation, and this patient might benefit from the stem cell transplant. And this is, again, looking at how these patients do behave. And as you know, patients who have high-risk disease, it's better to move towards transplant faster. And this one, obviously, these days we are using the revised IPSS, and it's available on the MDS Foundation website that gives us a better understanding about how the MDS is going to behave. Dr. O'Connell shed light about the natural history of MDS, and obviously why these patients need to be treated. These patients, for example, they develop low notificon, yes, and that's another big issue, that they could develop severe infections. Particularly patients, for example, if their notificon is less than 500 or 300, even if they are low-risk groups, there are some experts that believe that if a patient continuously has a notificon less than 300, it might be good to look at the possibility of a stem cell transplant. And then there is obviously transformation to AML in the natural history of MDS, particularly high-risk patients. These patients, there is this evolution to AML. When you look under the microscope at the bone marrow, you see these immature cells. We call them myeloblasts. I sometimes call them nastioblasts, because these cells are behind the progression of the disease to AML. And obviously, even those patients who have increased blasts in the bone marrow, refractory anemia with excess blasts, and CMML, 30 to 50% of those patients could progress to AML, and their survival is less than 2 years. That's why these patients need to be to have a transplant consult actually at diagnosis, because transplant is a process. Looking at the patient, finding a donor could take months. So if a patient is having a diagnosis of high-risk disease, high-risk MDS, it's better to be referred to a transplant physician early in the course of the disease. I talk about the blood transfusion and survival. Dr. O'Connell mentioned it in details as well, and that's why that, you know, I think that's another issue, that paying attention to the number of the transfusions. As I mentioned, if a patient is having at least 2 transfusions per month, or like in 6 months, this is that's something that we need to pay attention, and it could affect the survival of patients, those who get frequent blood transfusions. So when we look at the patient, as I mentioned, the high-risk MDS, they have either IPSS of intermediate to high. What are our goals here? To delay the transformation to AML, prolong survival, and then possible cure. Because as Dr. O'Connell mentioned, azacitidine or decitabine, none of these drugs are able to cure a patient, yes? They slow down the progression of the disease. They add months and years to the patient's life expectancy with a good quality of life. However, they are not going to cure MDS. So we have hypomodulating agents. They improve cytopenias. Patients could become even transfusion independent. That we know that they add months and years to the patient's life expectancy, and as I mentioned, they delay transformation to AML. Having said that, however, with allogeneic hematopoietic stem cell transplantation, we can cure MDS. The overall disease-free survival at 3 years is between 35 to 65%. However, there is an issue that when we get older, obviously, we can have some problem with like more comorbidities, organ dysfunction. So in patients who are older than 65, transplant could be more problematic. And about, I would say, 75% of MDS patients are older than 60. That's why I mentioned, you know, transplant could, it's not a treatment modality for every MDS patient. Now I'm going to change the gear and talk about, when we talk about the stem cell transplant, what we mean. So obviously we have a donor, yes? It could be syngenic. These are like an identical twin. One donates a stem cell for his or her donor, her brother or sister. Then we have allogenic. So we get stem cells from, we find another donor. It could be a sibling, it could be unrelated, it could be cord blood these days. We call it haplotransplant from like even parents. And then there is something, we call it autologous. We get the stem cells from the patient himself. This method, using the patient's herself or himself, the patient's own blood cells, doesn't work in MDS. Why? Because as Dr. O'Connell mentioned, that the factory is faulty, you know, that those stem cells have got already lots of problems. So you can't use it in patients with MDS, autologous stem cell transplant. We use autologous in patients like multiple myeloma and lymphoma. And then what was the source of the stem cells? It could be either bone marrow or blood stem cells. Bone marrow, those of you who are patients, you had bone marrow aspiration and biopsy test. The same thing how we get a bone marrow from a donor. We take the donor to the operating room under general anesthesia, 2 physicians on each side of the patient, and we use the same needle. We go into the pelvic bone and suck the marrow out and put it in a bag. We do a bit of processing, and then later on we give it to a patient. That's the bone marrow. With blood stem cells, we have a donor, we give him an injection, usually Nupogen, for 5 days, daily injection. On the 5th day, the donor comes to the transplant center, lays in a bed, we get blood from one arm, we spin it, we return the red blood cells, we keep the white blood cells which are full of the stem cells, and later on we give it to a patient. So this is peripheral blood stem cell. There is a bit of difference between these two sources of stem cells. With the bone marrow stem cell, when we give it to the patient, the recovery of the blood numbers in the patient is a bit delayed, and patients get less graft versus host disease. When we give blood stem cells, peripheral blood stem cells, the recovery is faster, and they get more GVHD. Why they get GVHD more? There is data that when we give blood stem cells, there are more T cells in that product, and these T cells are behind the producing or inducing graft versus host disease. So again, talk about how does autologous transplant work. So we usually give high dose of chemotherapy and radiation to the patient, and then we return the stem cells to the patient. This doesn't work in MDS at all. It's interesting that in patients who get autologous stem cell transplant, some of them later on could develop MDS because of that chemotherapy and radiation that they get. For example, there is data that in patients, for example, with lymphoma, who undergo autologous stem cell transplant, 10 to 15% of them later on, like after 10 years, could develop MDS. Patients with breast cancer who get chemotherapy and radiation, about like 5 to 6% of them could develop MDS down the road. So it doesn't work in MDS. In MDS, what we use, we give some chemotherapy and radiation to the patient, and then we give the stem cells, as I mentioned, how we prepare it to the patient. What is the role of chemotherapy and radiation when we give it? We wipe out the patient's bone marrow and immune system. Since we are giving the stem cells from somebody else to the patient, those stem cells know that they do not belong to the patient. They are from day one. So we have to prepare our patient's body. How we do it? We give high doses of chemotherapy and radiation. For example, sometimes we give 16 doses of a drug called busulfan. We give it over 4 days, 4 doses every day. We give 4 doses of a drug called fludarabine. Sometimes we give radiation. This combination, chemotherapy and radiation, wipes out the patient's bone marrow, wipes out the patient's immune system. So this usually happens over 4 to 5 days. Then we give 1 day rest to the patient, and the following day we return the cells to our patient. This is like a bag of transfusion. We hang it, and gradually it goes to the patient. What happens? Patients usually do not feel that much, but in about like 4 or 5 days after infusing the cells, they gradually start having they could have sores in the mouth, they could have diarrhea, and in about 10, 14 days later, gradually we see that the blood numbers go up. Until the blood numbers go up for about, I would say, 10, 14 days, when they have a very low blood numbers, they could have fever, they could have diarrhea. I call it miserable period. They really feel lousy. Like we usually give a Nupogen shot. We start around day 7, so it could improve blood numbers better. And then when the white blood cells are high enough, above like 2,000, the neutrophil is above like 1,500, we discharge the patient to home. And we start seeing the patient twice a week for 3 months. Why is that? Why we ask the patient to come to the transplant center twice a week for 3 months? Because there is data that out of 100 patients who undergo a stem cell transplant, in the first 3 months, 5% can die. Out of 100 patients who undergo a stem cell transplant, in the first 3 months, 5% can die. So in all transplant centers, if you go to any transplant center, they want to keep the patient close to them. So they say you need to, if for example you can't live in, for example, San Diego and have transplant in LA, it doesn't work because of the traffic. Patients could get sick quickly. They want to see the patient fast in their center. In the first 2 years after transplant, about it depends on the type of the stem cell transplant, full intensity versus reduced intensity, 10 to 25% of the patients can die. That's why I'm saying that transplant is a big stick. It doesn't, not every patient would benefit from it. I'm going to show you some data about the causes of mortality in transplant patients. So, what we should do for transplant, the patients ask me this question: should we do transplant early in the course of the disease, or wait like a couple of years and see how it goes? The data is that if you want to do transplant for high-risk disease, it's probably better to do it earlier in the course of disease. Why is that? If you wait longer, patients could have more toxicity of the chemotherapy. For example, they have frequent infections, and then if the MDS progresses to AML, that's a different ballgame. Why? You know, when MDS progresses to AML, we call it secondary AML, and secondary AML behaves differently from de novo AML. AML, which happens on its own, is harder to treat. The patients become resistant to chemotherapy faster. Even their outcomes when they undergo transplant is worse. So that's better to perform transplant early. That's why I said if a patient has high-risk MDS, it's better to get a transplant consult very early in the course of the disease. This is patients who get a transplant from their siblings, either brothers and sisters, and they were like 100% match. And this is patients who get transplant from unrelated donor. And again, the numbers is a bit lower than this one. Why is that? Because when we give, when the patient undergoes stem cell transplant from an unrelated donor, the incidence of, for example, GVHD is higher. So if you look at 100 patients who undergo a stem cell transplant and from a sibling, brother or sister, about 35 to 55 of them could develop graft versus host disease. But if it's an unrelated donor, about 60 to 80 of them would develop graft versus host disease. So that's why and graft versus host disease, it's a disease on its own, has got certain issues. So that's why that we prefer to find a brother or sister who is matched. But if we can't find, then obviously we could look at the unrelated donors. Any questions so far? Yes?
Let's say I would want to give my stem cells to my brother, and I'm a donor, I'm a candidate.
Sure.
For that. I'm 56, and doctor said maybe younger. You would prefer younger, but
Of course.
I mean, I'm younger than my brother. He's 63, so I'm just asking: is someone in the 50s able to?
Yes. At the end of the day, if you are a match match sister for your brother, as a transplanter, I would say and you are in good health otherwise. Yes, obviously, I would take you I would choose you as a donor. But there is data that younger donors, for example, outcomes are better. There is obviously a difference when in stem cells between younger patients and older patients. Older donors, the stem cells, for example, they could become a bit lousier. For example, we could have problem with engraftment. And there is some data that incidence of graft versus host disease is higher with older donors. But still, you are good.
Yeah. Okay. I have a daughter, so we could have even a younger donor.
Your daughter. So when we get 50% of our genes from each parents. Yes. So if each sibling has got 25% chance to be matched, full match for her or his brother. Yes, each sibling has got 25% chance. But your daughter, for her uncle, it's much lower.
Okay.
Any other questions here? Yes.
And I'm the other sister. I'm 51, but I have lupus. And so is that obviously,
we
is that a
usually-
problem with lupus or hepatitis A?
No, hepatitis A, it gets treated and it goes away. So and you get immune to it. So hepatitis A is not a problem. However, we usually shy away from patients from donors who have autoimmune disorders.
Mm-hmm.
We usually, unless we can't find a donor, most of the transplanters shy away from donors who have autoimmune disorders.
Okay.
But hepatitis A, no problem.
And if it's like I'm a lower level of lupus, I'm not at high level, so does it matter the level?
That's a good question. So it depends. For example, if obviously lupus is is a range and it's a group of disorders. If you are not in active treatment, if you are asymptomatic, those could be discussed. I think it would be discussed on an individual basis.
Okay, thank you.
Anything else?
Yes, hi. Is it true that a child is automatically a half match?
Yes. Usually, I would say because your child, has got 50% of his or her DNA from you, so you have a half match, and we call it haplo donor or haplotransplant. And these days, it's done routinely. Actually, it's not as easy as a full match, with 100% match, but still it works. It's more cumbersome, and there is more risk of graft versus host disease, more risk of infections early in the course of transplant, that 3 months period. However, we are becoming better and better in our supportive care, in treatment of those infections. So haplotransplants are becoming more common these days.
Do you recommend the related half match over an unrelated 100% match?
That's a very good question. So, these are my preferences. I prefer first a brother or sister who is 100% match. Then I prefer an unrelated donor, which is 100% match. If I can't find, then I would go to a haplo. There are sometimes donors which are like 9 out of 10 match. If I have a 9 out of 10 match, I might prefer that one to a haplo donor still. Because as I mentioned, haplo is tricky. There is more increased risk for graft versus host disease in that 3 months period. As I mentioned, generally speaking, 5% of patients can die. You get more infections, different infections, viral infections, bacterial infections. So I prefer even a 9 out of 10 match over a haplo donor.
Last question.
Yes?
The IPSS?
Yes.
You said that the bone marrow transplant kicks in around intermediate 2 and
Yes.
high. That's when you start to consider it?
Yes, but that's another good question. There's some type of is a developing consensus among some thought leaders that if a patient has low risk MDS, however, if she or he has some certain characteristics, for example, complex cytogenic abnormalities, or the platelet count is less than 30,000 and the patient needs frequent transfusion, or the patient is having transfusion 2 per month for 6 months, these patients might benefit from transplant, despite being low risk. So it's not that, Casey, what are your thoughts on this? Because, did you see that paper? I think it came in 2017 in Blood. There were some Europeans and Americans. They were mostly transplanters, though. They were not non-transplanters.
I think that the most important, I'm not a transplanter, so personally, I think the most important thing is to start acquiring the information about transplant while you're seeing your treating physician for the MDS, because if you find out there's no donor, that makes things easier, it makes decision easier. And they can start to search, where they're searching every 6 months or every year, so they're looking for someone to be a donor. So you really want to stack the deck up in your favor for the short term and for the long term. Yes, I was at the ASH meeting this year. There was a very nice talk with one of the former people from ASH, who's a transplanter. And there is some data to suggest going straight away to the transplant maybe is a benefit, but it's a little hard to sort that out, and I'm not sure what the right answer is. Obviously, we see the other side, at the good side and the bad side. We see the people that have done amazing, and then we think everybody should get transplanted, and then we see the people who have terrible toxicities or unexpected GVHD, and we think, oh, we shouldn't transplant anyone. So I'm not the right person to ask because I'm not a transplant expert, but the way I've interpreted the data is to say, let's start looking right away while we start thinking about treating you. And that way we know what our short-term plan is and we know what our medium-term plan is. And if the transplanters say, actually you're a good candidate, it's all lining up, let's go, then maybe we'll only do 2 cycles of Vidasa because they're ready to go. CMML is a disease that I do think we should go to transplant as soon as possible. I've learned my lesson over time with that disease. So that is one where I will kind of push early for that if possible.
I would like to, I use this expression that transplant is like getting into a roller coaster. You have been in a roller coaster? So you feel good, you go up, the next second, you are going to feel terrible. As I mentioned, transplant is not, I can't give you a rosy picture. I am a transplanter. My consult is at least 60 minutes, and I believe after finishing this 60-minute consult, if a patient and his or her family walks out of the room and they are not scared of transplant, I haven't done a good job. I'm honest with you. Transplant is scary. Why? We wipe out the patient's bone marrow. We wipe out the patient's immune system. We want to give the patient these new stem cells, and it takes sometimes not months, years to get it to grow back completely. Usually 12 months. You know, you lose all your immunizations. You become like a newborn baby. You remember, think about your children, those who have children. You know, children get sick frequently until the age of 12, 13, and then they get better. You know, you stop taking them to your pediatrician. Why? Their immune system gradually matures. In transplant patients, when we do transplant, they lose all those immunizations. We restart immunizing them around 6 months after transplant. And as I mentioned, in the first 3 months after transplant, 5% die. Yes?
Would that be a danger if someone has HIV? Because their immune system is suppressed.
Of course.
So what do you do, let's say, maybe he's a candidate, but chemo,
Yes.
chemo, what would that do to him?
That's a very challenging situation, because when we give that big doses of chemotherapy and radiation in order to wipe out the patient's bone marrow immune system, that HIV infection could get out of hand.
Yeah.
So that's usually, you know, HIV is not a very, it makes things much more complicated, much more complicated. Yes?
I was just going to say that I believe lunch is ready.
Okay.
It's 12 o'clock. Maybe we might have time for maybe 2 more quick questions, and then we'll break for lunch. Doctors Atari and O'Connell will be staying for lunch, so you may be able to catch them during lunchtime as well. And then this afternoon, when Aaron talks, we'll also have an opportunity for question and answers.
Okay. Oh, me?
Yes.
This is probably a dumb question, but why can't you just wipe out half of the person's bad stem cells with chemotherapy rather than all of them before you put the good ones in?
That's actually a good question. It's a smart question. Because we don't have that ability to guess which one, you can't cherry pick stem cells. So, as Dr. O'Connor mentioned, MDS is a disorder of the stem cells. The majority of the patients' stem cells have gone crazy, messed up. So that's why you need to get rid of them. Yes?
Like I said, I just have a transplant, and my donor was my sister. So the hospital says that her HLA type is perfect match to mine.
Yes.
Which is 12 out of 12.
Very good.
But usually when I have stayed in the hospital for transplant about 28 days.
Uh-huh.
And then all of our patients were talking about all the, what's your donor, what is your rate, what is your matching rate, things like that. I keep telling to them that I got donor, which is 12 out of 12, and then they kind of thinking, why you have 12 out of 12? And all other people were saying, oh, I'm like 8 out of 10, 9 out of 10, things like that. So, like, I know I'm lucky, but I don't know why.
So
how does the
sure.
additional tools come out from my case?
So, no, because we are becoming better and better in identifying the degree of being a match. That patient who got 8 or 9 out of 10 match, it was an unrelated donor. And when this matching goes down, you are at more risk for example, graft versus host disease. And the outcomes are inferior compared to a 10 out of 10 match. There is one more lady here. Yes.
I just wanted to say for anybody who wants to chat at lunch, I had a 12-12 unrelated donor 20 years ago.
Very good.
I'm happy to provide a quote to anyone here.
Very good.
I don't want to take up the time from lunch, but I'm happy to talk to anybody about
Sure.
transplant.
That's great.
We have Cindy in the back, 8 years post-transplant as well.
Yes.
Risk to the donor.
Say again.
Give you risk to the donor.
That's a good question. So if it's a bone marrow donor, so it's general anesthesia going, to the operating room, they would be sore in their back because we make holes in their pelvic bone. If it's a peripheral blood donor, they get this injection, GCSF or Neupogen, which stimulates the bone marrow to produce more stem cells. Millions of donors have used it. It's very safe. However, a handful of cases, for example, it could make our spleen enlarge. So a handful of cases have had like rupture of a spleen. A couple of cases, again, handful, like bleeding in the brain for the donors. That's it. Otherwise, it's a very safe procedure. Okay, I have a couple more slides. Should we stop here or should we continue? Go for lunch. Lunch?
If you want to go through the slides quickly, if you have a couple more slides.
Yes.
Okay, yes.
Is that okay, guys? Or can we?
Yes.
Very good. Okay, so as I mentioned, transplant could be like a roller coaster. No rosy picture, is scary, and that's showing you why patients can die. And this is after getting a stem cell from a brother or sister. Actually, as you see, the number one cause is, so this is the die within the first 100 days. Number one is primary disease. And even after, beyond 100 days, after that 3 months, the relapse, recurrence of the MDS is number one. And then as you see here, other causes, infection is a big one. Graft versus host disease, here is about 8%, here is about 7%. Patients could have bleeding, could have organ failure. That's why we keep the patients close to the transplant center for the first 3 months, and we see them twice a week. And this is, again, very similar. This is getting stem cells from an unrelated donor, and causes of it are very
Excuse me,
similar.
doctor, this is the statistics across all kinds of transplants, not just MDS, is that right?
Yes, all causes.
All transplants.
All
This is
transplants.
not the
Not
result from
MDS,
MDS.
yes. That's a good comment. And as I mentioned, there is a, as you see, big risk, big difference between low risk MDS and intermediate to high risk MDS, and that's why we talk always about transplant in these patients. This is a very good paper that from Harvard, which showed that if in low risk MDS, actually transplant didn't help patients that much, and their quality of life actually transplant brought it down. With non-transplant modalities, patients did better and they had a better quality of life. Having said that, however, in high-risk patients, those who get transplant, they did better and their quality of life was better. So that's why we, transplant can work, however, as I mentioned, in selected patients. So this is my summary. So transplant should be considered as an important, treatment modality, obviously intermediate high-risk MDS patients, and certain groups of low-risk patients. And should be done early in the course of disease. Is a big stick, not for everybody. Okay? And older age patients should not be excluded automatically without proper evaluation. Obviously we have physiologic age versus chronological age. Personally, I have done transplant up to age of 73. I had a 71 years old MDS patient who actually went back to work around 3 months, half part-time, 2 days per week. And about 6 months after the transplant, he was working like 4 days a week. He was a military contractor. He had a military background. He served in Vietnam. So, but it was interesting. And 71 years old. And I'll tell you something, that the outcomes are improving. So if you compare like 2018 outcomes with like late 90s, early 2000 outcomes, we are getting better. Why? For example, we have new drugs which control those infections in the very early post-transplant better. We have growth factors, we have better antibiotics. So transplant, if you, generally speaking, transplant in 2019 is very different from what it was, for example, in 90s or early, 21st century. And thank you for your attention.
I want to wholeheartedly thank Drs. O'Connell and Aktari. When I asked them to come today, they jumped at the chance. It's very difficult, I think, to present on a level that patients and caregivers can understand, and I think they did a wonderful job. So please thank you.
I'm here for the launch. I'm more than happy. This is my cell phone number. Is there my email? If you have got questions, just send me an email or call me. I'm more than happy to answer. No problem.
So lunch will be in the same room that we had breakfast in.
Okay.
It's ready.